I'm Thadi Mohan. I work as a consultant in AMRITA. I've been there for about 10 years now. And I want to share some of my experiences with you on Makoplasty, unicondylar technique. So the good thing is, 2 years back, if you had asked me if I did all these cases, I would have probably said no, because 2 years back I wasn't doing many, or I was hardly doing any unicompartmentals. But these have happened in the last 2 years. So, and our numbers are steadily increasing, which is the bright spot. This is the institute I come in from. All of you, I hope, have visited Kerala, and you're welcome to visit the institute as well. Just a word on the history, because robotics is what we are talking about today. So this famous science fiction author coined these terms nearly 75 years ago. And we are all familiar with the robots in the movies. And who can deny these speaking, performing good and bad robots? But if you go back, the earliest robot is actually 450 years old. It was during the Roman times. It's still around. It's called the Clockwork Prayer. It's in one of the museums. And it's been designed by a toy maker. And interestingly, this robot can actually walk a few steps at some allotted hour every morning, play with the rosary, and then go back. So amazing technology, so many years old. So I won't bore you with the history of robotics. It's been alluded to by Professor this morning. The Robodoc system started in the 1990s. Then came the Acrobots. And we are talking about the third generation Mako robot. There are incidentally 500 in the US, and there's only one in India. If you look at the broad types of robotics, there's the active system, where the surgeon supervises the robot online. The surgeon cannot modify the actions, but the surgeon can certainly interrupt, and the robot is capable of performing individual tasks autonomously. So that's where the Robodoc comes in. The passive systems, the surgeon maintains a control of resection. The robot cannot perform tasks individually. And in the semi-active system, which is the Mako robot, it's a surgeon-controlled milling. The robot uses force feedback, so that's a haptic feedback. I'll talk more about that later on, which can constrain the surgeon to safe zones. So, you have computer-aided bursts. The constraint is there, but the final control still rests with the surgeon. And then you have image-based and imageless-based. So the Mako robot utilizes the CT. Some utilize MRI, but Mako uses the CT for creating a more personalized 3D image. And there's a pre-approved plan before you do the surgery. And this plan actually helps in deciding or identifying the depth of bone resection, optimal component size, alignment, deformity correction, etc. And then there are the open and closed systems. The Mako robot again is a closed system. So you have one specific manufacturer's implants which are used, whereas in an open system, several different implants can be used. And the thing you have to remember in orthopedic robots is that we are dealing with hard tissues. It's not soft tissues. Bones do not deform. Bony landmarks, they allow for reliable and precise anatomic position which we need. In hip and knee replacements, we cannot err too much. We need a high degree of precision. So if you look at the Mako evolution, which is nearly 13 years old. It's not a recent thing. It started off in 2006, as you heard earlier. Earlier, the first things to come in were the unicondylar implants. The THA, the total hip, came in 2010, and total knee has been around for only 2 or 3 years. But there's a lot of clinical experience. There are more than 650 systems in use. Like I said, in the US, more than 500, more than 60 in Australia, about 3 or 4 or 5 in China, and we are catching up. The AMRITA Institute has an advanced center for robotic surgery. I think that is how they got interested in procuring more robots. So they started off with the Da Vinci, which is shared by several departments like urology, gastro, gynecology, and then they have the ROSA robot for the neurosurgeons. The CyberKnife is used by the oncologists, and the Mako robot was virtually handed over to the department on a platter. So in 2017, we acquired the Mako robot, which is really robotic arm-assisted arthroplasty. It's not the robot which does the surgery. It's the robotic arm which helps the surgeon in doing the surgery. So earlier we got the total hip and the partial knee softwares, and in 2018 we got the total knee software as well. So the Mako robot, really the system consists of all these equipment. There's a robot, and then you can see there are 2 consoles there. One has got a camera attached to that, and then the other one is a guidance cart, which is manned by a very trained personnel called the Mako product specialist. Now Mako has this arm to which you can attach either a burr, which you can see there, or you can attach a saw, or you can attach a reamer. I'll show that to you later on. And this is a certification you have to go through before you start using the Mako robot. Adarsh did a fantastic job in highlighting the importance of partial knee. So why are we performing partial knees? They're all equally successful to the correct patient, and we know thanks to the ligaments there's a better range of motion, better kinematics, faster recovery, and they're tolerated better, not just by younger patients, or my oldest patient is 80 years. So I think it's the choice of the patient. To the correct patient, it is the best option, and hopefully patients the feel is a much normal knee. So proper patient selection is the key. We have to start looking out for unicompartmental disease. I have started doing that ever since I have this fantastic tool available for me. And once you start looking, you realize that in the past there are so many knees that you have done where you think, it's not really fully worn out, is it? So once you do that, you have to really, you can start increasing your numbers. And then the other important thing which I find with partials exclusively is whatever the deformity, it should not obviously be very severe, but it should be passively correctable. That is the crucial part. If you find that the deformity is fixed, then it's much better to go in for a total. And in this case, since we are talking about the Mako robot, the CT scan is a must for pre-planning. These are the basic x-rays that we do. We do a whole leg bilateral full length x-ray of both the legs, the usual AP lateral views, skyline views, and then we do a CT scan which sometimes shows us some very interesting findings, like cysts which don't show up on routine x-rays, shows up very well on CT scans. So again, coming back to patient selection criteria, there has to be a range of motion of at least 10 to 90 degrees. There should not be any recurvatum. 40 to 80 years, like I said, I have my eldest patient is 80 years, and I have replaced, she's an American lady, and she's an ashramite, and she was insistent that she has to sit down and what best but a partial knee helped her do that. The BMI is controversial. Some of the American surgeons say more than 40 they will not consider a uni. I haven't found any patients that heavy yet. But of course, even I am reluctant. If it's more than 40, I think it is a risky operation. Osteoporosis again is, I think you needn't be very adamant about osteoporosis. I mean, unless it's grossly osteoporotic, obviously we wouldn't touch patients who have severe rheumatoid arthritis and things like that. ACL has to be stable. I feel ACL for me is a must for unicondylars. Some of the American surgeons have said they reconstruct ACLs and then do a uni, but I have no such experience. 10-degree varus, 10-degree valgus is fine. Anything more than that, I'll show you a case where I had to convert to a total. It has to be correctable passively. I told you the deformity has to be passively correctable. There should not be any global pain. I mean, many of these patients, when you ask them, they will point their finger either to the medial side or the lateral side or to the patellar side if it's a patellofemoral arthritis. But if they open their palm and they say, my whole knee hurts front and back, then chances are that there is tricompartmental OA. So let us look at the robotic partial knee workflow. It's basically a CT scan, like I said. Once you have seen the patient, the CT scan is performed. Segmentation is done. Basically, it's a pre-plan based on several landmarks. So you have a tibial pre-plan and a femoral pre-plan, which the Mako product specialists, they will create, and they discuss it with the surgeons. So you have to play an active role in that. You can't just rely on that and do it blindly. So I find that I spend more time discussing these plans in detail and understanding the patient's knee much better even before I go in for a surgery, which I think is a very good thing. There have been instances where I have just come into theater and started operating without really spending a lot of time assessing the patient's knee, because there are so many patients to go through on a busy list. But what I find is, as you spend more and more time with these cases, your time spent actually comes down. Earlier, during the first few cases, we were spending maybe half an hour, and now it's in less than 5 or 10 minutes, you can go through a full plan. And then there's something called post-capture, which I will show you. Intra-op, you do balancing, and then you do cartilage mapping. All these are done intra-op. And then the Mako system comes in and helps you prepare the bone for a final implantation. So pre-planning of the uni, let's go through it so you get an idea of what we do. So the screen looks something like this. It may look very busy, but actually when you break it down, it's really quite simple. It's got various views of in this case it's the tibial component. The transverse section, you can actually place your component the correct way, making sure that it is within the margins of the bone. It's not impinging anywhere. It is shape matching with the native bone. You can move it forward, backward, you can tilt it this way or the other. And there is one view, as you can see there, the top-down view, it's a dynamic view where you get an idea of how your components are going to actually move. And you want to ideally make sure that you can see green on either side of the blue, which means that the components are properly centered. So you have plenty of freedom to move the components on the tibia and the femur any which way you want to match it perfectly. You can also choose the size of your implant. What I have noticed is almost 99% we have never had to make any changes. Once the implant size is decided upon, it's always perfectly right. You don't have to go up or down. There's another thing that you have to get used to is these terms of arrays and checkpoints and probes which come with the robotic system. As you can see, we have got for total knees and partial knees, you have to put these arrays. These are bicompartmental markers which are going to be tracked by the camera system and helps communicate between the robot and the patient in real time. So these are the arrays, and here you can see an interesting foot holder, which also is something new. Once I started using the robotic system, I found this very convenient leg holder which can help you flex or extend the knee very conveniently without anyone having to hold it. So this is how it's fixed to the system. It's got a small a ball which actually slots into place, and just by clicking on that on the base there, the surgeon himself can move, flex and extend the knee according to whichever position you want, and it will stay very firmly held there. So these are the arrays I've been talking about, and you will see there is an array on the robot as well. So all these are actually recognized by the camera system to help you in the surgery. The robot, as you know, as you noticed, has to be draped, so it's covered in a sterile cover. Bony registration is something we do. We are actually communicating with the robot, and here we are identifying the hip center, the malleoli, before we actually start the procedure. So we place some checkpoints. There are checkpoints called there's one on the femur condyle, there's one on the tibial condyle, and I just want to show you this short film which will take us through a standard operation. So the pins are being put, the joint has been opened. We don't need a lot of retraction. A gel-P will do the job very well. Then comes the bone registration, which I've been telling you about. And here you can see, by putting a probe, we are actually touching several dots on the condyles. And as we touch the various points, the software is actually recognizing in real time the position of the patient, and this will help the robot in performing the burring, etc., or the sawing in total knee replacements. So this part of the surgery is worth spending time upon, because the more carefully that you do this, the registration is, if it's very good, it will give you a very clear picture of the robot also will work much better if the registration is better. So after that, once we've opened the knee, there are capturing of poses. This is done at various degrees. All these lines that you see there, they show that it's a bit loose, not too loose. It should ideally be between 1 and 2 millimeters. If it's going on to the orange, that means it's a bit tight. So depending on whether it's loose or tight in early, mid and late flexion, you can make adjustments intra-op, and that is the best part of this. Even after you have started the operation, you can still tweak the components, move it one side or tilt it another side, or rotate it a little bit, and then fine tune it before you actually start burring. And once you start burring, we use a 6 mm burr. The green part is what needs to be burred, and as we are burring it, it turns white. The peg holes are made both on the femur and the tibia. Wherever it shows red, it means you have gone either a bit too deep. The other thing is the enhanced safety feature which is available here, something called the stereotactic boundary or a virtual boundaries, so that when you are burring, if you touch the virtual walls, the robot will come to a standstill. So anytime your hand wavers or goes beyond the safe zones, the robot will stop you and then you have to restart again. So one feels very safe while doing this, and the posterior condyle or the posterior part of the tibia, you virtually don't even have to look, you don't have to put any retractors there. You just point the burr in the right direction and it will do the job. There's been, touch wood, no neurovascular injury so far in nearly 175 cases that we have done. So finally, after trial implantation, you make sure everything is moving well, there is no restriction of movement, it's balanced well, and then so you go ahead and do the final implantation. There's also, interestingly, a special instrument to remove cement from the back. That is my colleague, Dr. Jay Tilak. Okay, I think that should be the video. And then just a few more slides to reiterate the points that registration is the key, and you're communicating with the robot by doing the registration. This is an interesting case where the patient has had a high tibial osteotomy in the past 12 years ago, and he presented to us with a typical medial compartmental pain and wear and tear. So you can see how a CT is looking. It looks like something like Mount Everest there with so many hillocks. Surprisingly, when I opened the knee, the lateral side was quite smooth, though the picture looks different. I think it's probably the screws and all the plates which are giving all this. But the important thing here is, once you burst all these blue balloons, it verifies the registration to ensure that you are less than 1 millimeter away. This is a kind of a repeat of the video, so I will skip that. The other thing I wanted to show you is the cartilage mapping, which you do intra-op. The cartilage mapping ensures that the implants placed within the compartment are not too proud, they are flush with the rest of the cartilage. And once more, the centralized tracking and the top-down view ensure that your component is perfectly placed where you want it to be. Same thing with posterior slope, we try to match the native bone, and you can translate the component medially, laterally, even rotate it front and back to ensure that you got the best position. This, like I said, the white indicates native bone or resected bone. The green is the planned resection, and whenever you overstep or over-resect, it turns red. So going back to this great man, his first law of robotics was a robot may not injure a human being. And I think that concept has been incorporated in the Mako robot, in that the haptic feedback is a great boon. You know, like I said, the virtual window ensures that your saw or your burr stays within those margins, and you can't go either way and injure soft tissues. So you feel very safe. And incidentally, this gel-P retractor is the only retractor I use when I'm doing total knees or partial knees. And this is another interesting video which Gurua was talking about. The surgeons were, after some time you get so used to the burring that you look at the monitor, you stop looking at the knee where you're burring, and you'll be, it's almost like playing a video game. You'll be concentrating on turning the whole green into white. Incidentally, the burr is used only for the partials, be it unicompartmental or patellofemoral, and for the total knee, we use a saw. This picture I just wanted to share just to show you how precise the burring is. This knee has been, obviously we're doing a uni on this side, and you can see the rest of the knee has been untouched. The groove has been cut as pre-planned, and the best part is your ACL is still here, very much here, not a single fiber has been disturbed. And this is the 6 mm burr. Just to show you some examples of how in a patellofemoral, this is the pre-plan. The green part is where you wanted to do your burring for the trochlear plate, and post-burring, it's just a ditto image of what you pre-planned. And then you can put your implants in position. Again, a typical a medial uni knee. The Restoris MCK implants are used. It's got a fixed bearing, unlike the Oxford, which is a mobile bearing. I show this to share one of my patients who used to struggle to stand up. She had severe starting trouble. I took a good 5 to 7 minutes before she could, walk comfortably or reasonably well if she was sitting at a chair. So she always preferred to be on her feet, because she said she finds it more difficult to stand up from the sitting position. She's incidentally my mother-in-law, so I tried everything from steroid injections to visco supplementation, besides, of course, the usual NSAIDs. And when the Mako robot came, I convinced her to have a partial knee, because that's what she had. She had only medial compartmental OA, and she is 76. I'm happy to say she's very happy with it. You can see without any support on the side, she just stood up and walked. So that is post-op. That was her knee, and that's the post-op. So since then, we have increased our portfolio. We were choosing our patients carefully at first, but now we are quite confident doing bilateral medials, lateral unis, bicompartmentals, where you do a patellofemoral along with a medial uni, and then bilateral patellofemoral. So the range is increasing. I think all this is because we have such a reliable and precise tool with us now. So the steady increase in our numbers. And recently I was bold enough to tackle this gentleman who's got shortening and medial compartment OA. He's got HTO done 12 years back. I struggled to take off the screws, and I just managed to take the top screws off and did a medial uni. Is very happy with that. We did a small study to compare the position of the components following the conventional UKR and the robotic assisted. This was in the early days when we had about 22 knees robotic versus 12 knees conventional. So we looked at the various slopes, the valgus and the various positions of the components. And to cut a long story short, we found that the tibial implant placement in robotic arm assisted is far superior. Again, coming back to some of the points the earlier speakers alluded to, it's very important that you choose your patients well. This one case where, again, I was getting bold. There is a 15-degree varus here and a 23-degree varus here. So I had no doubt that the 23 side I will have to do a total because it's well past the recommended 10 degrees. But I thought the 15 side I might get away doing a partial because the deformity was correctable passively. However, we went through the usual CT scan, everything, and then on table I found that the ACL was missing. I mean, both sides it was missing. On the 15-degree side also it was missing. And like Guruva said, it's very important that you have the fallback option of doing a total, and which we had. So converting it immediately, the change of plan took only about 5 minutes, and then we went ahead and did a total knee replacement on both sides. But the lesson I learned was that you shouldn't compromise. If your deformity is more than 12 degrees, for beginners I would say more than 10 degrees, don't think of doing a unicompartmental. So in our experience, the benefits so far have been that now we are more confident in planning and execution. We have very good plans. The surgery is very precise. The shorter hospital stay is a big boon because now we are confident of sending our unis in 3 days. There is lesser pain, there is better recovery, it's safe, reproducible, there is a short learning curve of around 10 cases. And because ours is an institute, I find that it's a very good research tool, very good teaching and training tool. Thank you very much.